This recording is to cover a summary of the chapter on epilepsy surgery outcomes and complications by me and by Dr. Pilcher. The objectives of the chapter in a nutshell are to review outcomes of epilepsy surgery and its most significant complications. We start the chapter by reviewing the different seizure outcome classification systems. We discuss the angle classification system, which goes from class 1 to class 4, with class 1 being the best outcomes, patients free of disabling seizures, all the way up to class 4, representing patients with no worthwhile improvement with surgery. We highlight the limitations of the angle classification system, mainly being unclear quantification of the recurrent seizures. For example, in class 2, seizures are described as being rare and disabling. What is rare and disabling can vary as a subjective assessment from physician to physician. The same applies to qualifications like more or less without actually quantifying what the more or less really mean, prolonged without a specific determination of the duration, etc. So we discussed the pros of the angle classification system, being that it is the most commonly used. It was developed by professional consensus, ensuring significant buy-in from the epilepsy community, and it is easy to remember because for most of us it is reminiscent of tumor grading systems, which we learn in medical school. The second seizure classification system that we describe in that chapter is the one by the International League Against Epilepsy, which goes from 1 to 6 and uses much more specific quantification of recurrent seizures or auras, but its limitations being the complexity associated with requiring to quantify seizures to that extent. The second limitation is that it does not capture the dynamic nature of seizure outcomes. The third method of classifying seizure outcomes is time to first seizure, which is right now the most current way of measuring seizures, in the sense that it takes into account the dynamic nature of seizure outcomes. Patients have surgery, but some of them have their seizures recur in the recovery room immediately after the intervention, while others are seizure-free for years before their seizures recurred. A time to first seizure method of analysis generates Kaplan-Meier curves, a survival analysis methodology, which accounts for this variation in temporal recurrence and in duration of follow-up across patients. The main limitation of a time to first seizure analysis is that it does not account for disease evolution after that initial recurrence. In a way, a patient who just had one recurrence after surgery counts the same as somebody who had one followed by many. So the bottom line of all of that epilepsy surgery outcome classification system discussion in the chapter is more to inform you on what are the advantages and disadvantages of each method, so that you can make a more informed decision of conclusions drawn in the published literature. The second big section in the chapter goes over the actual seizure outcomes that are seen after the major types of epilepsy surgery. The we highlight several outcome predictors which have been described after either temporal lobe resection or frontal lobe resection or posterior quadrant resection. And for some of the main outcome predictors, we highlight in the chapter the rationale or the possible mechanism via which they could influence outcomes. And there are many, so you need to know that the summary that is in the chapter is in no way comprehensive of all of the different outcome predictors that have been identified. We next take the discussion on seizure outcomes to a more modern approach of evaluating outcomes after surgery, which takes the outcome assessment to an individualized level. We describe in the paper in the chapter some of the papers that we had published on individualizing outcomes after surgery, where we created tools that could be accessible in the context of an outpatient visit, where based on simple clinical characteristics, the surgeon can project the odds of seizure freedom and an angle class of 1, both at 2 and 5 years after surgery, for this one patient that they are now seeing in clinic. Since this is a very dynamic process and we continue and others continue to generate these tools for individualized outcome prediction, I am showing you on this slide the website that you can go to have access to the most current risk calculators related to epilepsy surgery. The last portion of the chapter goes over the complications of surgery and covers the main question that patients ask, which is it safe? And we go over a detailed discussion of the main complications and neurocognitive outcomes that could be seen after surgery, the assessments that we do to try to minimize those risks, and go over a detailed discussion of the specific surgical complications, including infections, bleeding, and others, together with the numbers for how often they happen, with the message that we want to convey at the end being that overall, for patients with drug-resistant epilepsy, surgery is the safest approach because the risks of mortality and the risks of cognitive decline are actually higher in those patients with drug-resistant epilepsy should seizures continue. With that, I will finish this recording and hope that you find the chapter informative. Thank you.